This is the first of hopefully many lectures, regular series of nursing education, just to make sure that we are, number one, covering the basics, and number two, refresher courses for people that are experienced. This is our first lecture, and we're going to try to iron out the kinks here, and if there are any things that we can improve on moving forward, we definitely will, but definitely wanted to just get things started with a quick refresher. This is something that we've talked about in the past. A number of years ago, there was a video made during the COVID pandemic when everybody had chest tubes. There was a talk on this during one of our nursing conferences that we had last year, so just a good topic to start off with, so chest tubes. So let's jump into it. Why do we place chest tubes? What are indications for chest tubes? And by the way, this is meant to be informal, so if you have any questions along the way, just shoot them out or just feel free to chime in. But why do we place chest tubes? Call them out.
Hemo for infusion.
Fusions. What else? Pneumothorax, effusions, hemothorax. What's another big one? Somebody comes in, fevers, chills, has an effusion, septic. How about empyema? Empyema, and I'm gonna put paramnemonic. You get it, effusion. So those are all indications, okay? So I split these up into two categories. Can anybody think about why I put pneumothorax over here, pleural effusions, hemothorax, empyemas over here? Right, air versus fluid, and really that dictates where the chest tube is going to go, okay? So I went to medical school, I didn't go to art school, so y'all can't make fun of my drawings, okay? So you have your patient, and you have your lung, okay, and we're gonna designate this left and right, pretty patient, okay? So you have your effusion, right? And so either one of us from the pulmonary side or the ER gets called to the bedside for one of these issues, and we go to place a chest tube, right? Really, our goal is to resolve whatever is going on. And so if we have a pneumothorax, air rises, what we want to do is place a chest tube that goes a little bit higher up, right? Because air rises and we're going to catch everything there. A lot of times what you'll see is chest tubes being placed like either medially or they travel a little bit lower. I don't want to get too far into that, but I do want to kind of bring this to your attention because this is something that you can kind of keep track of and look at moving forward when you start to troubleshoot, right? So pneumothoraces, usually we like the chest tube up high, as opposed to pleural effusions, hemothorax, or empyemas, where the chest tube, we like to put it in the middle or even down low. We like to aim down low. So when we place the chest tube, well, let's back up. Back in the day, we as in the medical community, used to place the chest tube and drain whatever was going on in the patient's pleural space into a jar or into a bucket or whatever at bedside, right? As you can imagine, there was some complications with this. Can anybody think about some complications or potential complications from just taking a chest tube and just putting it the other end into a open container out in the open, not contained or anything like that? Infection or gravity, infection. And what about if there's an opening, clotting, and then air coming back into the system, right? So not ideal, right? So this was a collection bottle. And so we wisened up over time and we started to close the collection bottle off to the environment and we made another bottle called a water seal, okay? We would take some water about 2 centimeters high of water, cm, of water, and we would take a tube and put it down there, because now when the patient takes a breath, air is able to leave the chest tube. Air is able to leave the pleural space in the chest tube and get drained into the collection tube. But when the patient takes a breath in, negative inspiratory force on the chest tube, we're not able to get any air back in because it is now sealed off by water to the environment, right? We place this at 2 because I'm not going to get too far into it, the intrapleural pressures and whatnot, things that give us PTSD. It takes about 2 centimeters of water to kind of overcome some of those pressures. And if we are breathing normally, about 2 centimeters of water will keep the air out and allow us to drain fluid and air out into the environment, okay? So a water seal. But this was very long, tedious process and everything. So several years ago, we decided to speed up the process by adding a third bottle. Suction. And so what we would do in that case is add a third bottle, and we were able to connect this system to wall suction and able to start pulling out air or blood or infection or the effusion. And we were able to do that. Now, we are able to set the wall suction. Usually what we do is set this to 80 centimeters of water or to 100. 80 to 100 usually. And we are able to dictate how much suction we have that the patient sees. And the way that we do that is by setting the height of this water. And usually we set this to 20 centimeters. And based on the height of this water, we're able to set, again, how much pressure or how much suction the patient sees, okay? So usually the standard is about 20 centimeters of water, and again, that kind of keeps everything nice and neat, but we can increase this. The higher the water, the higher the amount of suction the patient sees, okay? So this is the 3-bottle system that we were taught in medical school, the 3-bottle system. So you got your collection tube bottle, you got your water seal bottle, and you got your suction bottle, okay? So, as you can imagine, having 3 bottles at the bedside, very tedious, a lot of opportunity for patients, especially agitated patients, to kick over the bottle, or frustrated nurses to kick over the bottle. So, years ago, we came up with this device, all right? Atrium. Atrium is a proprietary name, it's the name of the company that creates this. So, there are actually 2 types of atriums. There are wet containers, and there are dry containers, wet and dry. Anybody think about why they call it wet and dry?
What goes in the container? Is wet or dry?
True, right? But going back to the 3-bottle system, it really has to do with this 3rd bottle, okay? I told you that based on the height of this water, we can control the amount of suction that the patient sees. In a wet container, you'll have a column over here that you fill up with water to either 20 centimeters, 30 centimeters, 40 centimeters, and that dictates how much suction the patient sees. But that got to be a little messy in terms of agitated patients kicking over things, and it was very noisy. You would hear this rumbling continuously, that sort of thing. So they improved on the system and came up with a dry system. And so you have these 3 bottles now in this system. You have your collection bottle or your collection chambers, okay? You have your water seal chamber, water seal chamber, and then you also have your suction bottle chamber, okay, that you can use to connect this. And so I just took it out of the box, or the packaging, and again, very remedial. So you have your water that you put in, and where do you put this again? You put this through the tubing, in the little bottle, blue container. And so you squirt it in, and then you have this water that goes in and it turns blue. It has blue coloring here, just so everybody can see it nice and neat, right? And so what you usually do is after the proceduralist inserts the chest tube, you connect one end of the chest tube to the atrium through there, sterile technique. You want to make sure you tape this in to make sure you get a good seal, number one. Number two, you don't want to have any disconnections at this area. And then, depending on what we have going on, after a conversation with the provider, we're either going to place this to wall suction, or we're going to place this to water seal, or we're going to do something else with it. But most times, 9 out of 10, probably 10 out of 10, we're going to place this initially to wall suction, okay? So whenever we do that, we should, depending on the situation, initially see some rush of air. All right, and the way that we determine that is that we look at our air leak chamber from the water seal chamber, so the air leak detector area, and we might see a couple of bubbles initially, and that's a good thing, right? Because if there was any air that was introduced into the patient during the procedure, we're evacuating that. If there is a pneumothorax going on, we're evacuating that. So some air bubbles initially are okay, but when you have a time where you have lack of air bubbles and then you see them again, we might have a problem, right? We'll talk about that in a little bit. But so we have our air leak detection system, but we also have this column right here that detects our intrathoracic pressures, okay? And basically with normal tidal volumes, with a patient that's breathing spontaneously normally, you'll see this rise and fall, okay? And that's good titling, just maybe a couple of centimeters here. Lack of that could be a good thing, could be a bad thing. We'll talk about that in a second. But the other thing to keep in mind here is that what we place our settings on. So we have attached the patient to wall suction at negative 80 to 100 centimeters. And then what you should see, and by the way, you place the suction right here. And so what you should see, by default, this is set at negative 20 centimeters of water by default. You can increase that to negative 30 or negative 40. That's a conversation with the provider. Usually the provider handles this part, but usually by default, it's at negative 20. If it's set at negative 20 and you have some pressure that's higher than that, again, by default, usually you set the wall suction to negative 80 to 100, you'll see this bellow come out, okay? You'll see this bellow come out and it'll hit this arrow. If you have wall suction to negative 10, you might not get that bellow all the way out there. So if I set it lower, over here, that bellow may not come all the way out to the arrow. If I set it higher to negative 30, negative 40, that bellow will come out. I'm having trouble. There it is. If I set it higher, the bellow might exceed that arrow. If I don't have enough wall suction, that bellow may not reach that arrow either, okay? So just some things to keep in mind when you're evaluating your chest tubes. You need to look at that bellow and see where it is in relation to that arrow, okay? Because that's part of troubleshooting. Again, you have your collection chamber, and you want to make sure that you are accurately determining how much output you have per your shift, okay? What really helps us out is that we have accurate documentation of what's going on in the chamber. So basically from a nursing standpoint, what we should be doing on a daily basis is number one, going into the room and assessing the patient, number one, okay? And basically just to keep your thoughts organized, you assess your patient and you just kind of trace everything back to the atrium and making sure that there's no issues along the way. So when you assess your patient, if you walk into the room and the patient's giving you thumbs up, talking, conversive, no issues and all that, chances are we're not having any major issues, okay? But you still want to continue your assessment. If you walk into the room and the patient's grabbing at their chest and, tachypnic and everything, then you want to make sure that you troubleshoot your chest tube and make sure that it's not an issue with the chest tube. But you start with the patient's looking good, and then you kind of trace down, right? So you want to look at the dressings, you want to make sure that the dressings are not saturated, there's no blood coming out of there. You want to make sure that the chest tube is not dangling from the chest wall. I've seen that a couple of times. So you want to start there. And then after you've done that, you want to kind of check your tubing. This chest tube works best when it is below the patient. If the chest tube and the atrium are higher than the patient, you might have an issue. What I sometimes walk in and see is that the patient's laying down and you have the chest tube and it's kind of higher up here and then it goes down to the atrium. That's not going to work because it has to overcome this gravity in terms of draining. So you want to make sure that the chest tube all this is kind of falling downwards, okay, aiming downwards. You want to just assess the tubing itself, make sure that there's no cracks in the system, make sure there's no leaks or anything. Again, another common area where there's problems is the chest tube itself and the connection here. So you just want to make sure that this is all sealed and connected, and you want to check your tubing here because one thing that can happen is when nurses go to change out the atrium, stuck here. You get the point. Change out the atrium. Sometimes this is not connected properly. So you just want to check your system. And then you want to check the atrium itself. A good way to ensure that we are documenting apples to apples is that when you go in, you assess where the level is at the end of your shifts. When do you usually check, at the end of your shifts or at the beginning? Beginning of the shifts? Both? Okay. So usually at the end or the beginning of the shift, one of the nurses will come in here, see where we're at, make a mark, and it would be super helpful if you record the date, the time, and the amount drained during your shift. Okay? Date, time, and the amount drained during your shift. So for instance, when we first place the chest tube, if we drain 100 out initially, okay, and then at the end of the shift, we get 100, and then at the end of the second shift, we have the levels at 160. It would be helpful if you dated, timed, and put 60 mLs, okay? 60 mLs, because that would dictate how much we drain during that shift, okay? Take note of how much fluid is drained, because if we start draining a lot of fluid during a shift, if we're draining like 400, 600, 800 during a shift, that's probably an issue. Bring that to the attention of the provider. The other thing that is good to take a look at is your air leak chamber, making sure that there is no new air leak going on, how severe the air leak is. You can see that there are levels to this, right? So you have 1, 2, 3, 4, 5. Somebody with just like a small little air leak, like a little occasional bubble or two, whatever, that usually reaches this number 1, as opposed to somebody with a moderate air leak. You might hit 2 or 3 bubbles, the 2 or 3 level here in terms of bubbles. Somebody with a raging air leak, it'll hit bubbles in this 5th chamber here. So that really grades the air leak for you. Okay, so you can start to talk apples to apples in terms of, I have a small air leak, moderate air leak, large air leak. Also make note of the intrathoracic pressure here. So I told you that normal spontaneous breathing, you should have just a little bit of pressure right here, a little titling, maybe 2-3 centimeters of difference here, as opposed to somebody who has a high intrathoracic pressure. So issues that would cause that: number 1, somebody with a lot of air trapping. So somebody with asthma, COPD, had a pneumothorax from that. Sometimes that can indicate some obstruction of your tubing, okay? So maybe there's a clot there that is causing some increased pressures intrathoracically and you're not draining properly. Somebody with a expanding pneumothorax, so if you have somebody with high intrathoracic pressures, a raging air leak, that would indicate maybe you have a worsening of a pneumothorax, maybe even tension physiology starting to form there. And then again, I want you to note where we're at in terms of our suction. Note your orders in Epic, okay? So on our end, we should be doing a good job accurately placing orders in terms of where we need to be in terms of our suction. Do we need to be continuous wall suction, 20, 30, 40? By the way, when you're placing the patient to wall suction, never place the patient on intermittent wall suction. Place the patient on continuous wall suction. Always should be continuous wall suction. We talked about air leaks. We talked about assessing the chest tube. One other question that always comes to mind is transporting patients. Transporting patients, is usually a case-by-case thing. We usually get calls from staff in terms of, hey, does this patient need to go down on wall suction? Can this patient be disconnected? What I will tell you is that we need to go back and we need to be on the same page about why the chest tube is in place in the first place. All right. So for somebody with a pneumothorax, this patient should be on wall suction as much as possible, especially with a new pneumothorax. For somebody with a pleural effusion, hemothorax, empyema, we can start to play around with that a little bit in terms of wall suction, okay? But for somebody with a pneumothorax that needs to go for transfer and all that, transport to another area of the hospital, that patient should be on wall suction as much as possible. So we troubleshooted, we kind of went over anatomy here. Let me stop there. That was a lot, sorry, but any questions on that so far? Clear as mud? What else did I miss? What else did I miss? But yeah, just in general, just remember in general, always look at the patient first, okay? Look at the patient. If the patient's doing okay, you see a little bit of air leak, that's generally okay, all right? We can deal with that. But if the patient is in respiratory distress, you're seeing high intrapleural pressures, raging air leak, that's a problem. Call for the provider. Another thing that I want to empower you guys to do is start assessing the chest x-rays yourself. You guys have access to imaging just like we do. And so when they come around to do a daily chest x-ray, and that's something that you guys should always, kind of take note of, patients with chest tubes should get a daily chest x-ray to make sure that the chest tube is in place. And what you should see on the chest x-ray is you should see that pigtail that is in the pleural space. I don't know if you can see that there. The pigtail is in the pleural space, and you see the holes. Oh, sorry. And then you should see the side ports in the pleural space. If you see that the pigtail is starting to dangle in the skin there on the chest x-ray, there's a problem. Call the provider. But you guys should be empowered to look at chest x-rays yourself too, okay? And if there's any questions on that, absolutely call the provider.
Did you go over first steps in a patient in distress with a pneumothorax with a chest tube in place? First assessment, like first thing to look for?
Air leaks and whatnot.
No. So patient with a pneumothorax, chest tube in place, but is in distress, to look to see if the tube is has been clamped.
So that's the other thing too. Thank you. So we will then start to wean the patient after a couple of days of the chest tube. We will start to wean the patient. And what we will do is turn the patient off of suction, place them on water seal, and then we will probably repeat some imaging. If that looks good, then we will start our clamping trials where we start to clamp the patient, and it's almost like a chest tube is not in place. And if that looks good, then we liberate the patient from the chest tube. Sometimes we do the clamp that you see here. Sometimes there's a 3-way stopcock that we clamp. We should be communicating that with the patient. But one of the first things to do when a patient is in respiratory distress and they're being treated for a pneumothorax or something else, by the way, is when you're assessing down the line for the chest tube, one of the common issues or one of the common things that you'll see is that chest tube is clamped, right? And it's not going too well for the patient. So basically in those situations, unclamp, and then at that point, you probably want to turn the patient back to wall suction, call the provider.
You can always do all of those steps before calling the provider.
Absolutely.
It's not going to hurt the patient.
Absolutely. Absolutely. So unclamp the patient. So basically you want to look for kinking. You want to look for any sort of clotting. You want to make sure that the chest tube is unclamped. Basically, you want to make sure everything is patent, everything is draining, no clamping. You want to check the three-way stopcock, make sure that it's properly in the right position, and just make sure everything is patent if the patient's in respiratory distress. Good. All right. Clear as mud? All right. Good. So again, a recurring thing that we're going to be doing here, nice and casual, no formal things, but if y'all have any questions on any of this, always stop one of us and ask. But this unit should be the leaders in terms of chest tube management. Dr. P said he's going to spread the gospel to all the other units to get everybody else up to speed, but we should be leading the charge here in terms of chest tube management. The other units, if they have questions, should be able to come to us with any sort of troubleshooting issues and management and that sort of thing. All right? Cool. Y'all have a good day.